Good morning, one and all. I am Dr. Prabhu CS, Professor, Department of Radiology in Sri Lakshminarayan Institute of Medical Sciences. Today, I'm going to talk about a very important part of obstetric ultrasound. There are multiple names to this scan. We can either call it as anomaly scan, target scan, or just plainly a second trimester scan. What is a target scan? A target scan is done at 18 to 22 weeks, even earlier in some cases when the mother has had a previous history of an abnormal child. And there are a lot of other things that we have to be remembering for this target scan. We should always check the prior scan that is done for this pregnancy and confirm the gestational age and the number of fetuses. If there are no previous scans available, assign the gestational age as per the head circumference of the present scan. So the head circumference and the BPD will become the standard for the gestational age if there was no previous scans. And as discussed earlier, that there should be always as low as reasonably possible principle that has to be followed for the reduction of fetal exposure to ultrasound. So the scan should be done within 20 to 25 minutes. If you're not able to do it, we can ask the patient to rest for some time and then do it again. If we are not able to get certain parts or certain angles or certain views on day 1, we can also ask the patient to come on day 2, because each and every view is very important to rule out particular anomalies and for documentation. Also, please remember that we should always have a systemic approach and a PACA checklist on what we report. We should also remember the rule of 3, which I will tell you about in the coming films. Also, regarding the survey, start with the fetus and then go to the fetal environment. That means fetus, biometry and the structures, and then the fetal environment in the form of liquor, uterus, placenta, cervix, and all those other things. In the fetus, to begin the scan with, there are multiple things that we have to see in the target scan. Now, this is of utmost importance because if we find out an anomaly, we can suggest for termination of pregnancy. And this has to be done between 24 weeks, before 24 weeks. So the timing of the anomaly scan is of very importance. If we do an anomaly scan at 24 weeks, then the medical termination of pregnancy by law is not permissible. But up to 24 weeks, it is permissible. There should be 2 reports from 2 different radiologists before terminating it, and the findings should correlate. There are some anomalies which are lethal and some anomalies which are non-lethal, and some anomalies which will be a part of a normal lifestyle, and some anomalies which can have gross lifestyle changes. So based on the mothers or based on the couple's comfort and the prognosis, the decision to terminate pregnancy can be calculated, or the decision on whether to continue or not can be assessed. So to start the scan with, we start with the fetus, as we told, and then we'll go to the fetal environment. Start with the fetus. There must be a systematic approach. It's always better to start with head to toe. So in that ways, we'll see the head, the face, the thorax, going to the abdomen downwards, the heart, then the spine, kidneys, upper limb and lower limb. Some also follow their own ways, but it is always to have a checklist of these things so that they don't miss a finding. In the head, there are 3 things that we have to see, or the 3 things that we have to remember according to the rule of 3. The first is the biparietal diameter plane. and then is the transcerebellar plane, and then the left ventricle cavum septum pellucidum plane. Three things, three planes we have to take images from. Let's go to the first plane, which is nothing but the biparatal diameter plane or the transthalamic plane. Now this is the plane, so you can see here is the plane where you will see the thalamus, which is an arrow shaped structure. Here we can see this is the tentorial leaflets, and the one in the center is the third ventricle, and on either side of the third ventricle we see the thalamus here. Now this plane is where we will calculate the biparatal diameter, and the biparatal diameter will be calculated from the outer margin to the inner margin, and it should be transthalamic. Now this is a diagrammatic explanation, and the corresponding ultrasound image, you can see the arrow shaped structure of the tentorium. You can see two thalami, you can see the midline interhemispheric fissure, and then you can see the cavum septum pellucidum, and the measurement of BPD is done from out to in. Now this is the ideal plane to measure the BPD, and here you can see it is corresponding to approximately 18 weeks 4 days, which is ideal time for doing a scan to rule out anomaly, or the second trimester anomaly scan. Now the second plane is the left ventricular CSP plane. In this plane, we should be able to see both the left ventricle and the cavum septum pellucidum. Here a diagrammatic representation where we see the left ventricle or the lateral ventricle. I'm sorry. In the lateral ventricle, we see the choroid plexus and the lateral ventricle CSF space. And anteriorly, we will be seeing the cavum septum pellucidum. Now, this is a plane that we have to measure the lateral ventricles, and as well as the choroid plexus can be seen as an echogenic structure within it. So the upper limit of normal is 10 mm. So we can give it as prominent or mildly dilated ventricles or ventriculomegaly if it is dilated further. And here is a corresponding image where you can see the cavum septum pellucidum anteriorly, and then the left ventricle or the lateral ventricle here with the echogenic choroid plexus. So a small note on the cavum septum pellucidum, it is just behind the corpus callosum and just anterior to the bithalamic plane. It will be seen as an anechoic structure. As you can see here, it is filled with CSF. It on either side, you can see the anterior horns of the lateral ventricle. The last plane in the head is the transcerebellar plane. Here we will see a dumbbell-shaped cerebellum, and the corresponding ultrasound image, we can see the dumbbell-shaped cerebellum. We have to measure the transcerebellar diameter at this location, and it usually coincides with the gestational age. And we should also calculate the retrocerebellar CSF space. Now this anechoic space behind the cerebellum and the occipital bone is called as a retrocerebellar space. And anteriorly to it, we also see an arrow shaped structure, but this is not the thalamus, but this is like we are slightly lower down, and this is part of the brainstem. Anterior to that is the thalamus, and anterior to that is the cavum septum pellucidum. And here we can see part of the interhemispheric fissure in the midline and anteriorly. As you can see on the either side, we can see the cerebral hemisphere, and it is just starting to sulcate. So you can see like some indentations. So this is like early sulcations. Sometimes we can have some additional views, like this is a coronal image taken posteriorly. This is the nicely seen cerebellum. You can see the retrocerebellar CSF space, or this is at the level of the foramen magnum. And you can see that there is the maintenance of the dumbbell shape, and there is no any descent of the cerebellum into the spinal canal. The next thing, face. So normally the rule of 3, we should see the nose mouth view, the profile view, and the bilateral orbits. The PMT view is also indicated, but it is not indicated as seen in the first trimester. So this is the profile view. We can see this is the head. You can see the nose, the palate, the lips, and the chin. This view is very important. It tells us any abnormality in the nasal bone, the orientation of the nasal bone and the nose. It gives us an idea about the lips. It gives us any idea about the chin, whereas there is any micrognathism or macrognathism. Also, you can see a structure here. This is nothing but the tongue. We can also rule out any tongue abnormalities like macroglossia and other things. This is a very important view. It should be there in your image list. The next thing is the nose mouth view. This is also very important to rule out cleft lip. So you can see here the two nostrils, the nose, the upper lip, the lower lip, and the opening to the mouth. And this is nothing but the chin. Now here we don't see any cleft lip or cleft palate. The third plane is the orbital plane. In this orbital plane, we see the two orbits with the globe. We are seeing that they do not have any protrusion to the exterior. That means there is no thalamus. We can see that the lens is seen as a small echogenic line, and drawing a line between the centers of the two orbits will give you a distance which is approximately equal to the gestational age, which is approximately equal to the transcerebellar plane in most of the cases. The other thing, the same eye in the coronal view, you can see nicely the globe, and you can see nicely the rounded lens. Sometimes we can see the hard palate, as you can see, as echogenic line. This is the one side, and this is the other side, and this is the central part of it. And much more lower, we can see the hard palate, which is partially ossified. We can also measure the nasal bone in this plane, in the mid-sagittal plane. As I told you, all these views has to be taken. But the most three important views is the profile view, the nose mouth view, and the orbital view. The PMT line is not that important, but we can calculate that as well. Next, coming to the thorax. We should see bilateral lungs and the cardiac situs in the thorax. As you can see here, in this film, that we have taken the image at the level of the fetal thorax. And in the fetal thorax, we should estimate the cardiac axis or the situs of the cardia. And here you can see that the apex of the cardia should be in the same direction, or it should be pointing towards the side of the fetus where the stomach lies. So this is a cut which is down taken somewhat caudally through the level of the stomach. So the stomach is on this side of the vertebra. And here you can see that the heart is also facing the same side. Now, one of the first things that we see in the thorax cut is to look at the cardia, the spine, and the location of the stomach at a much more lower level. The other thing that we have to look at is the position of the stomach in relationship to the vertebral body. Here, in this case, we can see that this is the vertebra. To draw a clock face, keep the spine at 12 o'clock. We should look at the position of the stomach. If the position of the stomach is at 11 o'clock position, then the fetus is probably in the breech position. That means if the fetus is in breech position, the stomach should be at 11 o'clock position in relationship to the vertebral body. in terms of a cephalic presentation, as you can see in this case, you can see that the vertebra is at the same level, but you can see that the stomach is at 1 o'clock position in relationship to the stomach. 1 o'clock, 3 o'clock, or on that side of the clock. Now, this is very important to determine the situs. And this will be used to calculate or will be used to assess the cardiac axis as well. So in this case, the child or the fetus is in the head on position and the stomach is at 1 o'clock position in respect to the vertebra, and the heart is also pointing towards the same direction. So this is a normal situs. Same image in the breech position or head up position. You can see that the stomach is at 11 o'clock position and the heart is in the same direction. In the thorax, we also have to take a sagittal image on either side of the thorax, on the right and the left. On the left, you might be seeing some part of the heart, and on the right, we will be seeing the pure lung, which is seen as an echogenic structure as it is filled with fluid in the fetal period. And you can see the diaphragm and the abdominal contents clearly separated by a thin line-like structure. That is the diaphragm. On the same side on the left, and you are seeing the stomach bubble on the left side. So this is a normal appearance of the thorax and the diaphragm in the sagittal plane. Next, we'll go to the abdomen. In the abdomen, there are 4 things that we are worried about. AC view, which is nothing but the level at which we will calculate the abdominal circumference. The stomach bladder coronal view, the cord insertion, and the 3-vessel view. So these are the things that we have to take. First thing is the abdominal circumference level. So we should make sure that we do not include the lungs in this session. We should make sure that the kidneys or the adrenal are not seen. We should make sure that the stomach bubble is seen and a part of the portal vein is also seen. Now this is the ideal plane to take the AC. Here you can see it's a very nice ideal plane, and the rib is also seen at the same level without any break. As I told you, we should not be able to see the kidney or the lung or the adrenals as well. Abdomen in the coronal plane. We are doing this coronal plane abdomen so that we can see the bladder and the stomach in one shot or in one plane. Sometimes, as in this case, we have not seen the bladder, so we'll have to wait till the bladder fills. Probably the fetus had urinated just then, so we have to wait for at least half an hour to 45 minutes for the bladder to refill again, and then we have to take a similar view to show the stomach and the bladder view. And here it's very clear that the heart is on the left, the stomach is on the same side, but there is no bladder. So we should wait for some time and take another image. The last thing is the cord insertion and the 3-vessel view, through which we can confirm that there is a normal cord structure. Now, the cord insertion is very important because you can have some umbilical hernia in the form of omphalocele or gastroschisis. So for this view is very important. And the last one is the 3-vessel view, where the umbilical cord, after it enters the stomach, it goes inferiorly. The 2 umbilical arteries will go inferiorly and wind round the bladder. And we should get a typical image, like one is towards the probe and the other one is away from the probe. So one is blue and one is green. One is blue and one is red. It can be either ways, it can be tilted, but we have to see 2 colors, and that confirms the presence of 2 arteries, and the one vein will go cranially upward towards the liver. The next thing that we have to see is the heart. In the heart, there are a few things that we have to see. Very important is the first 4 the 4-chamber, the RBOT, the LBOT, and the PAS view or the 3-vessel view. The arch view is also part of the fetal echo. Here you can see this is the 4-chamber view, the first plane that we will be taking in the heart. This plane is obtained just by moving the probe cranially from the AC plane or the abdominal circumference plane. From there, we just move the probe cranially towards the fetal head. When I'm saying moving the probe is not same as tilting the probe. So moving the probe you have to literally move the probe towards the fetal head. That will bring you to this plane where you can see the heart as a 4-chambered heart, the 2 atria posteriorly and the 2 ventricles anteriorly. There are certain rules that we have to follow to identify the morphology of these chambers. Now, the left atrium is that chamber which is close to the vertebra, and it is that chamber where the pulmonary vessels come and drain. Now, that is the morphological left atrium. The morphological right atrium will be slightly bigger, and it is the place where the SVC and the IVC will come and drain. The morphological right ventricle will have the moderator band, which will be slightly smaller, and the morphological left ventricle is towards the left, or which forms the apex, and which will have the papillary muscles, and sometimes you might be able to see the caudate tendon clearly in the ventricles. From that, we can get the LVOT, which is nothing but the left ventricular outflow tract, which arises from the left ventricle and it goes into the aorta, and here you are seeing the aortic valve. You should also get the RVOT, which is this structure here. This is the pulmonary valve, the main pulmonary artery, giving rise to the right, the left main pulmonary arteries behind the pulmonary artery, aorta, and the SVC structure. So this is the RVOT. Just move a little bit cranial. You will see the arch view as a V-shaped structure. And if we do a color Doppler, you can see that the direction of blood flow in this both arteries will be in the same direction. The last view will be the PAS view or the pre-vessel view. The PA being the pulmonary artery, the A being the aorta, and the S being the SVC. Now, this all completes the fetal echo part of it. You should never forget to take the fetal heart rate in the same mode itself. The other thing that we have to remember is whenever we are taking a fetal echo, you can see that the image is zoomed in and occupies more than 75% of the screen. The heart is the main structure that we are concentrating on. So we should see whatever we have discussed, the 4-chamber, the LVOT, the RVOT, the 3-vessel view, and the arch view with color Doppler. All those things should be complete in our evaluation, along with the fetal heart rate. Now, there are different schools of thoughts on using power Doppler for fetal heart rate or using M mode. M mode is safe always. Power mode has to be kept as low as possible according to the ALARA principle. The next structure that we have to see is the spine and the kidneys. Now, it is very, very important to see the spine in the sagittal view, in the whole entirety, and in the axial view, so that the skin covers the whole of the spinal cord from the cervical region to the coccyx, which can be well appreciated in the axial images. We should also see the bilateral kidneys with the renal pelvis measurement, and we should measure the renal pelvis in its AP diameter. Here is a longitudinal image or a sagittal image of the fetus, and as you can see, the fetus should lie downward. That means the fetal spine should be the first structure of the fetus that is close to the probe. You can see that the spinal cord has 3 dots, 3 ossification centers. You can see it is continuous from the cervical region, thoracic, lumbar, and the sacral region. So there is the skin overlying this spine is also intact. We have to check the spine in the axial cuts as well. In the axial cuts, we are supposed to three ossification centers as 3 dots, and this should be seen at all levels. We should also make sure that the skin is seen at all levels overlying the 3 ossification centers of the vertebra. The other thing in the abdomen is the kidneys, we have to make sure that we take the kidneys in the axial plane and we measure the renal pelvis, as this can tell us whether the child is having a normal kidney, normal KUB line, that is a kidney ureter bladder line. We can expect some amount of pelvic ectasis, which is approximately 4, 7, and 10 mm, 4 at 20 weeks, 7 at 27 to 28 weeks, and 10 mm in the third trimester. So beyond that, we should put it as mild, moderate, and severe. Otherwise, we can use the word prominent renal pelvis for follow-up. And the AP diameter of the pelvis at the renal hilum is what we should measure. We should also show an image of the kidneys in the coronal plane. So you can see here, there are the two kidneys, one on this side and the other one on this side. And you can see there is mild prominent renal pelvis. We can also see the renal arteries at this level. The central structure is the aorta, from which two arteries arise. This can give us a clue if there is any renal agenesis or any other abnormality in the vessel from the coronal view of the abdomen. The other thing that we have to see is for the lower limbs. Now the lower limb, we have to look at the femur length, the bilateral tibia and fibula, and both foot. Now these three has to be in the image. First, the femur length, we should compare it with the opposite side as well. It should correspond with the gestational age. And then we have to take tibia and fibula. In the tibia and fibula, we should be seeing two echogenic lines which are parallel to each other, and it should be of the same size on both right and left. In the same plane, we should also make sure that the foot doesn't come or is not seen in the on-face view, because if that is seen, it is an indication of congenital talipes equinovarus, which is not a lethal anomaly, but which you have to mention in the report. As you can see in this case, we can see the tibia and the fibula as two parallel lines, and you don't see any part of the foot. The same thing here, we are seeing some part of the foot, but not the plantar aspect. This rules out CTEV. Another view to rule out CTEV is to look at the foot per se in the on-face view. You can see the foot here, and you can see the foot here, the plantar aspect of it. Now in this view, you should never see the tibia and fibula. If you see the tibia and fibula, there is a possibility for CTEV. Next is to go into the upper limb. In the upper limb, we should see the radius ulna, the humerus, and both hand. So just like the tibia and fibula, the radius and ulna will be seen as two parallel structures, and it should be of the same size on either side. The hand, even though this is not a compulsion to take, and a polydactyly is not a lethal anomaly, some radiologists don't prefer to take this. With this, the fetal workup is over completely, except for some part of the fetus we have not seen. For example, the fetal ears, we have not seen the fetal neck. So all these things can be seen, but is not in the ISWA guidelines. When to go about talking about the fetal environment, we have to talk about the placenta, the liquor, the fetal activity, the cardiac activity, and the maternal cervical length. All plays important part in the continuation of pregnancy. The first thing is looking at the placenta. We should label it whether it is anterior, fundal, posterior, lateral, and we should also make sure that we include the lower part or the lower margin of the placenta and make sure that it is not close to the internal os. As you can see here, this is the cervix here that is seen nicely, and you can see the internal os, the internal opening, and the inferior margin of the placenta is quite far away from the internal os. So this is helpful for us if there is any placenta previa. . As I told you, we should always measure the distance between the lower edge of the placenta and the cervical internal os. The next thing, during the second trimester, it is not advisable to calculate the AFI in 4 quadrants. Instead, we can calculate the single deepest pocket, which should be approximately 2 to 8 centimeters. Apologies for mentioning it as millimeter. The other thing is to measure the maternal cervix. Whether to measure it in transabdominal or transvaginal, it is a personal choice. But an ideal method of measurement is the transvaginal scan, which will give us a true picture of the cervical length. If transabdominal route is chosen, if it is clear, it is not wrong to do it. But if it is being obscured because of the head, or it is obscured because of the position of the fetus, then it is ideal to do a transvaginal scan. With this, I would like to end my presentation here. Thank you for listening.